given a couple of CME talks through Hinduja and elsewhere also. So what we normally land up doing is we try to teach radiology, which becomes very difficult for everybody to understand. So this time I'm going to try and make it a little different, and let's not build the suspense further and move on. So when in regular practice, when we when the clinicians face patients, be it on an OPD basis or in the casualty, and when they need radiology investigations, what happens is there are so many options available in terms of X-ray, ultrasound, CT, MR, etc., but not necessarily that each one of them is pertinent at that particular point for that patient. Either with a headache, altered sensorium, loss of consciousness, seizure, stroke, trauma, these are the various presentations. And in each situation, the investigation choice is going to be different. So let's go through some examples. This is a typical case of trauma where you're seeing a subdural hematoma, an extradural hematoma, a fracture, beautifully depicted on the CT scan. Various types of bleed in which there is a large cerebral bleed, a small external capsular bleed, and a pontine bleed. Other forms of bleed in which the patients not necessarily present as a stroke but as a headache, as in this case where there is a subarachnoid hemorrhage because of an ACOM aneurysm. So the CT, brain and the angiography was done at the same sitting. And sometimes they present with altered sensorium or loss of consciousness when there is a fall, and that triggers an acute on chronic subdural hematoma. Occasionally what happens is an MRI is done initially because the patient has presented with a symptom apart from an acute infarct. So in this patient, the patient had a seizure. And what we saw on the various sequences on the MRI was there was a different appearance and it didn't look classically like a bleed. So if there is the sequence known as GRE, now we also have other sequences. This shows clearly that this is blood. It is a technique which is used specifically to diagnose blood. If this is not there, then this itself can be misleading. In stroke, as I'm sure all of you all know, that there is a stroke protocol MRI which is done, and this is a large infarct which is seen involving the MCA territory, and there is something known as a diffusion weighted sequence which depicts the infarct far more earlier as compared to a routine imaging which is done in MRI or for that matter a CT scan. Same thing applies for a posterior fossa infarct where the patient is extremely symptomatic and you can't see anything on a CT scan, but MRI is extremely sensitive to pick up small infarcts which are the cause of the condition. So what is the role of CT then in infarct? Yes, CT is done, as I showed you earlier, when you have patients who come with stroke in an acute setting, you can do a CT with an angiography. But apart from that, whenever there is an established infarct and then you want to see whether there is any mass effect, whether there is any midline shift, what are the changes on follow-up, or if you've thrombolized and you want to see if there are any hemorrhagic transformation areas on the CT scan, that is all possible. And lastly, when there is a surgery which has been done for decompression, then post-operative follow-up is done on a CT scan. So I've highlighted all the points through the examples, and most important is trauma and any intracranial bleed. CT is irreplaceable, it is faster, it is quicker. And on the other hand, if you do an MRI and you do not do a complete study, then it can be misleading, as I showed you in an example where there was a bleed which would not have been possible to diagnose only on the basic sequences. MRI is definitely superior for acute infarcts, but in the window period, you can do a CT and a CT angiography to rule out a bleed and to see if there is any large territory infarct which has already been established. Spine, commonly, it is going to be MRI only, and there are various presentations. So let's go through some examples. This is a case of multiple sclerosis. This is neuromyelitis optica, where there is a coarse signal, and Guillain-Barré syndrome. And the last one, which is the commonest, I think, bread and butter of an MRI, this is a herniated disc, which is compressing on the thecal sac. So MRI is very useful for the spine evaluation. For thyroid, ultrasound is the gold standard, and in fact, there is no other modality which will replace it as far as evaluation of thyroid nodules goes. Here, there are various examples of different types of thyroid nodules, which are very well seen and in fact FNAC proven. And the USG-guided FNAC can also be done in thyroid. So there is no need for any other investigation for evaluation of these nodules. Salivary glands, one, depending on what the symptom is, like in this case, there is a duct calculus, a submandibular duct calculus and a dilated duct which is seen proximally. If not seen very well, one can do a CT and see them better. This patient has bilateral ductal calculi. And for neoplasms, MRI is more useful when we are looking at deeper involvement of the glands and better morphological assessment. For paranasal sinuses, CT is the best modality. X-ray is also used, but when you want to evaluate more in detail, X-ray is not sufficient, and we need a CT both for the diagnosis and for the follow-up in case after medication or after surgery. So this is a case of sinonasal polyposis. This is a chronic fungal sinusitis, and one exception to the rule is if you have invasive fungal sinusitis, which was very, very commonly seen after the first wave of COVID in diabetic patients, where the MRI with contrast is required to assess for the extent of the involvement by the invasive fungal sinusitis. So what is the role of CT in neck? It has various indications. One is, suppose there is a large goiter or a large swelling and we want to see whether it's extending into the thorax. What is its relationship with the surrounding structures? As you can see, this is a goiter. So this will require a CT prior to a surgery. In this, ultrasound will not be enough. Ludwig's, any acute neck emergency, we will do a CT scan, whether it be a Ludwig's angina or a Lemierre syndrome, etc. Whenever there's any diffuse involvement, infection, edema, we will do a CT. And for oropharyngeal and laryngeal malignancies, CT is preferred. You can see that there is a neoplasm here in the tonsillar fossa and necrotic nodes. I hope that there are, the misconceptions have got decoded after all these examples. The clinical background, old scans, lab investigations, we need all of that to understand the abnormality better. It is a misconception that if we have all that, we will get a bias. We have so many patients who tell us that we will not give you the old scans because you will copy that report. No, it's not true. There may be so many things on that scan which will help us in understanding the disease better. For example, if there is a CA breast and you have a vaginal nodule, which is an adenoma, you don't want to call it a suspicious nodule on all your old scans just because you don't have the old scan. Or if there is a polycystitis, but if we are not aware that there is an obstructive jaundice component, we may not look at the CVD better, or we may not ask for an MRCP. So it is important that there's collation of all the data and that is provided to the radiologist at the time of the investigation. Second is that it is sometimes not possible to get all the information on one modality. You may need one or more modalities for diagnosis. Does not mean that it's being missed on the other modalities. It's just that one needs more than one thing. And oral contrast, I would like to specify, most of our patients do not like to have it, but it is not a personal choice at all. It is a requirement, a part of the study. And without that, it is not possible to diagnose many conditions. Angiography is different from contrast. I think I have said that so many times that angiography is a separate indication and it has to be asked for separately. CT is not always better than ultrasound. As I've shown you, in thyroid, in gallbladder, ultrasound is way better and it has to be asked for over a CT scan. Similarly, MRI is not always better than CT. And when you have trauma, you have to ask for a 3D CT scan and not a plain scan because the reformats which are done are not the same. And it is important to know newer techniques, like there is CT Cisterno, there is CSF flow studies, etc. So the new studies are in addition and they give more information to the already existing knowledge of the disease, and it is important to be aware of them. Thank you.